directly entering the other. Sorry for being late. Just for just 2 minutes, I guess. Uh, yeah, actually, I'm really sad because I've just heard that one of the best ICU doctors I've known just passed away because of Corona in his 50s, and are very, very disappointed. And yeah, not on a great mood, but we have we still should go on. Yeah, I wanted to show you before we. I think that's you and me today, so I will just start with the uh, bright side of the life. Last week, I said that we had the scoliosis operation. Like, this is the 70 years old girl. You see the vertebra. This is the vertebra of hers. Like, this is the grade 4 scoliosis. Like, yeah, grade 4. The thorax, this is the hardest and most difficult part, the thoracic part, where if you make a one wrong move, you will leave the person paralyzed, okay? Because it's does not just limbs, but the whole arms also, the spinal cord that controls the movement of the four of the limbs. And that's the electrophysiologic monitoring. So we put the electrodes on the muscles of the extremities and the dorsum as well to, and we how to say, keep a track of the potentials. And if we make we are closer to nerve damaging, it just gives us wrong impulses, so we just stop there and don't go there. So it helps us to be in the track, in the correct I would say direction, and it warns us if we're doing some damage. But unfortunately, fortunately we had no such thing, and the patient is totally um, she's walking, and we're gonna discharge her on Monday. And this is the post-op picture. Do you remember this, how it was? Like, this is her spine before the operation, like this, the curve. And this is the, yes, before that, and now, you see? This is how it looks from the sides. All the screws aligned beautiful in the vertebra, starting from TH3, it means the thoracic third vertebra, till the lumbar vertebra. So, like, yeah. So that's the best outcome we could hope for, because stage 4 is the most difficult at this point to correct, because all the deformity, the muscles are used to the wrong deformed condition. It's relaxing, it's quite dangerous, because we cannot use on this operation muscle relaxants, because it will we cannot obtain potentials if we are using relaxants. The electrodes, the electromonitor will simply will not work. So that's the difficulty of the surgery. And but we managed to do the text on 100%. The patient is walking and ready to be discharged. Yes, it will be there forever, because the scoliosis is very bad disease. Because if we take them off, even if this whole vertebra solidifies, it will still start to bend. So this have to stay all the time if they don't cause any discomfort or irritation or rejection of the material, which we have not accounted any of such cases in our career. Yeah. What do you do with someone with scoliosis? Do you try to pull the spine back into normal? So that's, we screw up all the vertebrae, and then we use rods to correct the deformity. And on these roads, physiologic curves of course are maintained, and this holds the like a carcass, metal carcass that holds the vertebra correct in a correct position, and it prevents the bending more and more, because scoliosis, she will continue, otherwise she will continue to bend, and then the lungs will collapse because they're already pushing over their threshold to work because they formed cavity. And she had I will show you the intraoperative pictures as well. So this is the when she was lying on the table, like you could actually see her ribs, because of deformed ribs. We resected 4 of her ribs, so she's like like this is 4 of the ribs we resected because she had deformed like the quasimodo. Yeah. Yeah, how painful would it be for the patient post-surgery until it's healed? 3 days, only 3 days they're suffering from pain, and we need the narcotics like morphine and promadol for the analgesia. After 3 days, the pain just goes on, and when they're on the fourth or fifth day, we let them sit, and on the fifth day they just walk, and after they walk, the pain disappears. So that's the miracle for that. On the fifth day, they're walking, and in 10 days, we're discharging them. Yes, that's a quick healing. Yeah, but it takes 1 month to completely heal this bone with this metal construction, and 6 months it will be covered up with zones of bone, because we have taken out some parts of the bones in order to and for the new bones to grow over these screws and rods. Okay. So total rehabilitation is 6 months, but in this time, the patient still goes the life she had before. She's walking and doing everything she could before the surgery, and even more. Yeah, yeah. Lots of the doctors have passed away, the ones that cannot be replaced, the ones that are irreplaceable, and that is just the families or their team lost their mates, but the whole medicine, Georgia medicine, lost this grants of the due to corona, so that makes me really sad. mm, yeah, but that's the sad reality we have to, yeah, endure, unfortunately. But the vaccine is in America, the healthcare workers are already getting the vaccine, and let's hope that it will achieve us soon enough, soon before we have even more casualties. Yeah. Sorry for the bad news, but I also showed you the good, right? Yeah. I hope to. Uh, Hello, Michaela. Welcome to the lecture. So, actually, I hope that we would be more today, but I understand this is the week before the Christmas. I know we're just getting closer to the holidays, and you just yesterday had the midterm, right? How was your midterm, by the way? Did you pass, Michaela, Philip? Did you pass the midterm well?
Yes, I passed, but it was really hard.
Oh, that's really nice to hear. I know it was harder than the first one because the material itself was hard and a lot. I know, but I'm really glad to hear that you passed. Yes, for the exam, um, yeah, because the plus 3 chapters. Yes, specific because the including the cases, including the pathologies, and the previous one was just the definitions and the rules, which I find less necessary and more easier. So, but the finals will include the pathology. So finals will be more like the second midterm. So, but the majority of the questions I will use them for the finals. So if you repeat the questions which you didn't understand, or which you remember still while the memory is still fresh, note them, please, because they will help you and guide you in the finals as well. Okay.
I can't remember which ones I got wrong though. That's the thing.
I understand you. I was like the student like you, because the tests were like for me this the momentous ones. I kept forgetting them the minute I solved them because yeah, and especially the ones that you know correct and you know the correct answers. They are simply forgetting after the exam. And but the ones that you've been thinking about a lot, you will remember the ones. Okay. The ones that were a bit harder, you will still be able to remember them. Okay, anyways, we have today to finish the fibrosis and systemic disease effect in the bone. But before that, I wanted to show the Philip's presentation, which he sent to sorry, I've lost the folder. The
Sorry, I didn't realize I could send mine. I've got it. I can send it to you right now.
Okay, you can send it to me. Yeah. Or you can share your screen after me, okay? I will
Okay.
now show the Philips, and after that you share the screen and show us, okay? Okay, thank you. Now this is the Philips. Oh, here we have. I thought I said to choose out of the odontogenic tumors. Philip chose the odontomas. So this is I really liked Philip. Thank you very much. And you sent it right away. I asked, so the prompt answer and the immediate. So the features. I haven't talked about odontomas, so let's read it together. So we've got permanent dentition as the primary effect. Very rarely do they affect the primary dentition, and they can cause the diastematis, which is the gap between the teeth, aplasia, which is the reduction in the number of the teeth which develop, interference with the tooth eruption, and they're described as the mixed odontogenic hamartoma. Okay. So it arises from the odontogenic epithelium and odontogenic mesenchyma. So I heard someone. Okay. Oh, is it? It's not. Okay, sorry. I will start from beginning. I thought I shared it. Oh, okay. So I start from the beginning. This is the odontoma, as you can see, and this one I've read. Yeah. So arises from the epithelium and odontogenic mesenchyma, commonly found on the second decade of the life in the 20s and so on. Once developed, growth ceases and it remains dormant, waiting to be identified on the radiogram and waiting to be excised. Actually, it's the a bait for the surgeons, and differentiated as the compound or the complex odontoma based on the size and the structure of the growth. So this is the size in the bone, for example. It varies starting from the 6 centimeter in the length. So if we measure this one, it's actually 3 centimeters, like starting from here to here and here. Only large odontomas have the potential to produce small expansions in the bones. And the compound odontomas are the ones that have many randomly dispersed major small pieces of the hard dental tissues and resembles deformed teeth and it can sometimes contain enamel, dentin, and even the pulp spaces and contains a gravel-like appearance. Okay, so these ones are compound odontomas here, and this is the histology of the odontoma. You see bony structures, the primarily found in the maxilla and dispersed small dispersed pieces, and 60% the compound odontomas are found in the anterior maxilla, the favorable location of the compound odontomas. And the complex odontomas differ from compound ones as they only have one large mass of the disorganized tissue with the radiolucent rim instead of the many small pieces in the dental tissues. So one large mass, complex, and compound composed of many mass, but totally could have the same shape, the same size. Regular in shape, they have and have mass of the calcified tissue. Okay, so that's why they should be defined and differed from the osteomas as well. While the majority of the compound odontomas are found in the anterior portion of the maxilla in 62%, the opposite is true for the complex odontomas. 70% of them are found in the mandibular first and second molar area. So the location could be crucial for the differential diagnosis. Okay, because with appearance on the radiogram, if you are not able to detect them, though it's easy to detect them, you can at least exclude one or the other according to their location. Okay, odontoma are removed by excision or the curettage and all together, and the curettage. So this is the bony parts removed. Surgery. As odontomas do not adhere to the bone, they can be removed by hand curates. Recovery in the younger patients with an extensive removal or compound odontoma can see bone regeneration within 9 and 12 months. Okay. So the reason I am reading it because I know Philip's microphone doesn't work, so that's why I presented in instead of him. And thank you very much, Philip, uh, for your interaction and um, yeah, or responsive student, one of my best students. Okay, thank you, Philip. And now, Michaela, can you share your screen and can you present your PPT? Yes, thank you. Just simply push when the button present now and choose the table, the window you want to present.
Sorry, give me a second.
That's
I'm
okay.
gonna
We can wait as much as
I'm
you
using
need.
Google Chrome and then it's trying to make me do security things. So I'm just gonna log back in and come back.
Okay, that's okay. Thank you. Okay, meanwhile, I'm gonna show you. Oh, she's back. Yes. Yes, we are seeing your screen. Odontogenic myxoma. Good choice. Just open up the PPT. We're seeing the whole screen of your MacBook. Yes, we cannot hear you because I think you are not speaking. But the microphone is on because it's not showing mute. I think you should allow for the audio and video all together. Like confirm both of them, and you will be able to.
Yeah, I confirmed
Yeah.
it. I just wanted to present it.
Yes, now I can hear you. Just present the.
Can
So try
Can
again.
you see me now?
No, we cannot see the screen, but we can hear you. Okay, don't worry. Take your time. We have still a lot of time, so don't worry. Just yeah, push the present now and choose the window you want to present, because we could see the whole screen, but you can simply choose the one with the PPT.
Come on. What is happening?
We lost her again. Yes, I think we're good.
Oh my gosh, sorry.
No.
It didn't know what me using Google Chrome. Sorry bad.
Yes, that's great.
So today we're talking about the odontogenic mysomas.
Mm-hmm.
So I'll just give you sort of a brief history about it. So in sort of 1863, Virchow was the one who sort of termed mysomas. He coined it. But it was later in like sort of 1947 where it was Goldman and Thoma who sort of first described what a myzoma of the odontogenic origin was. So in terms of like they gave a description of where the site of occurrence and the age that it typically affected people. So in terms of what it is, so it is also known as a odontogenic fibromyoma or a myofibroma, and it's a benign tissue tumor. Sorry, so it's not metastasizing, so it's not entering circulation to other parts of the body, but however, it's locally invasive. So it's able to infiltrate into nearby tissues, and typically they're quite healthy and it sort of affects it as well. Um, it's quite slow progressing. So it tends to, in sort of order to sort of have like a visible mass, it typically occurs over like a period of a few years for you to like notice the difference. But if a patient is typically going to have regular dental visits, the the uh, the ability for the dentist to catch it is a lot quicker than like compared to someone who does not visit the dentist often, or maybe like they have social economic sort of factors that prevents them from going to the dentist, and it gets to a size where it's noticeable, and it most commonly affects the mandible. So in terms of incidence, it typically affects like 0.5 to like roughly 20% of the population. Um, and it occurs in like the second and fourth decades of life, so like from the ages of 10 to 40 years old, and it peaks at like 30 years of age, and it's sort of in terms of the ratio of men and females that it affects, it typically affects women a lot more than it do men.
Yeah.
And in terms of the histogenesis, so mysomas typically are exclusively in the jaws. It rarely affects like other bony sort of tissues, and it originates from so it sort of affects mostly like we said the mandible, but it can affect the maxillary as well. But in the mandible, it tends to like the posterior region, so where the premolars and the molars are, and it's sort of derived from to dental mesenchyme. So, sorry, I've got something. So, from dental mesenchyme, and sort of radio microscopically, it sort of resembles dental pulp tissue and follicular cellular tissue as well. Sorry, let me
Yeah.
know if I'm going too fast. Sorry.
No, 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 no. That's okay. Thank you. I like your the way of presenting. Very beautiful uh, background and the pictures.
Okay,
Go
thank you.
on, please.
Uh, in terms of symptoms, and these symptoms are not in every single patient. It typically varies in individuals based on the size of the lesion as well. But typically, these are the most common symptoms seen. So, like pain, ulceration where the masses, and then you have paresthesia. So you can have like this numbness or abnormal sensation in the affected region, and then
Yeah,
typically, tooth mobility is quite seen. So where the mass is sort of pushing into against the tooth, it sort of makes allows it to move.
yeah.
So I gave a case study
Mhm.
to illustrate this. So we have
Sure.
a 26-year-old patient. I will show you the picture in the next one.
Mhm.
So she sort of presented with like a painless progressive swelling that affected the lower left side of her face. So she initially noticed that the swelling grew into the current size that it is over like a period of 1.5 years. The patient had no sort of coexisting sort of dental or medical histories that could have made that the mass happen, and she had no history of trauma.
Mhm.
And then sort of extra oral examination sort of showed that she had this non-tender sort of bony hard swelling upon palpitation of the lower left region of her face. And it was about approximately like 3 to 4 centimeters in size. So she had no fever. She had no abnormal sort of swelling size of the lymph was not seen, and no change in the color of her skin. So she didn't have any like translucency or any darkening of that area. And then from the picture, you can see around here that there's a slight asymmetry of her face.
Yeah.
And in
Noticeable.
terms of intraoral examination, so we had localized swelling, so where the mass was present, which was hair. Um, as you can see, you can in the picture you can see the displacement of the first molar, but there's also displacement of the second premolar as well, and it sort of uh, caused the rest, like the adjacent tooth, to also have mobility in it. So from this, you can see that there's no ulceration or any sort of discharge coming from the mucosa.
Mhm.
And then radiographic examination, you can see so a ortho pantomography showed sort of like multi-ocular radiolucency. So you can see with this one, you sort of have like poorly, it doesn't have well-defined borders, it instead has like a poorly defined border with sort of scalloping, if you
Mhm.
can see that. And even here, you can see the displacement of the premolar and the second premolar and the first molar, and then the movement of the tooth.
Mhm.
So, in terms of histopathology, these cells, the myzoma, sorry, is typically characterized by these like stellate spindle-shaped cells, and they're embedded in this sort of mucoid extracellular matrix with these cytoplasmic processes. I don't know if you can see it quite in the picture that I've put in.
Mhm.
So I have shown you all of this in terms of treatment and all of that. Before we give treatment options to the patient, all of these factors in terms of like clinical examination, radiographs, the histopathology, the sex of the patient, the size of the lesion, all these things matter in terms of making an accurate diagnosis. So especially to differentiate from other odontogenic tumors, this is really important. And in terms of treatment options, we have curettage for like the smaller lesions. These are the ones that are quite like about 1 centimeter in size. And then for surgical resections, you sort of have it for the larger masses. And depending on how large it is, you can need an add-on reconstructive surgery to sort of fix the symmetry of the patient's face, or just for better facial aesthetics.
Mhm.
And it's also really, really important to always follow up within like a year after the removal of the mask, because there's a really, really high incidence of reoccurrence with these tumors. Um, yeah, and that's it. So thanks for listening.
Thank you very much for presenting. It was very informative and very beautiful. Thank you very much, Michaela. Um, thank you. What maybe Philippe or Hussein have questions? Do you have questions? Did you enjoy it just as much as I did?
Yes, it's very, very good presentation and information. It's very good
Mhm. Yes, thank you,
and
Michaela.
informative. Thank you very much.
Thank you. Thank you very much, Michaela, Philip. And what about Hussein? Have you prepared something for today?
No, because I have no time because of the exam. But for
Okay,
next
how was
week, I
your
can
midterm? Did you
prepare.
pass it?
Yes, of course, very good.
Okay. Okay, nice to hear that.
I have
Okay,
only
you can send me, you can
one.
send the PPT if you will be able to prepare. You can just send it via mail if you don't want to
Yes,
present it.
yes, of course. But you can
Okay.
tell me which topic you need for which topic.
Odontogenic tumors, choose one of them, okay? Because
Odontogenic.
yes, because there were lots of them and I didn't include many in my PPT, so I left it to for your reading and yeah.
Okay, yes, of
Mhm.
course.
Okay. Thank you, Michaela. Thank you, Philip. I really enjoyed it, both of the presentations. And to be more fair, yeah, of course, Michaela, thank you very much because oral and visual together makes up an on point presentation. Thank you very much. Okay. Yeah, it doesn't mean that the Philips one was somehow no lesser of a presentation. Thank you, Philip, too. I know his um, microphone doesn't work, so that's why yeah, because he's one of my favorite students. I just, yeah, I cannot complain about. Yeah, thank you. Okay, okay. Okay, so I will. I'm glad for all of my students, especially for those who attend every lecture. It doesn't skip my attention, of course. I know, and if there is any help I can give you in the finals, and I can assure you that you are one of my favorites. So I will do everything possible, of course, to help you guide through the exams. Of course, and I hope that you will pass the rest of the exams with the flying colors, okay, as well as the midterms. Okay, now actually, the fibrosis and systemic disease affecting bone is the shortest chapter of all in the book, in the big book we've got. And so I've almost discussed all of the pathologies. I will just quickly remind it to you, and the lecture will be, yeah, today will be short because I know it's Saturday, week before Christmas, and last week's gonna be the final one, and we have just one chapter left to discuss, so we are in no hurry. So we talked about the primary hyperthyroidism, that is the the disease, a systemic disease that affects the bones in the whole body. And primary, it means we've got the secondary one. Primary is due to the local lesions in the parathyroid gland. It could be the tumor of the parathyroid, should be the cysts of it, or a developmental I would say damages that cause the primary hyperthyroidism, and that is of course that just like the secondary one, it is caused by the hyper secretion of the parathyroid hormone, which is PTH. And it you see the bony lesions that it causes, and differential diagnosis usually should be run from multiple myelomas, hypercalcemia, sarcoidosis, adrenal insufficiency, and others and others. I had a case he presented with a femoral breakage, which just the sitting up position during the sitting up, because the bones were so fragile and they're so poor for with the calcium and minerals, they just snap and break easily. And yeah, and anorexia and weight loss, abnormal weight loss, is also one of the clinical features of the primary hypercalcemia. And scoliosis as well, spinal deformities, kyphosis and kyphoscoliosis, and the salt and paper appearance on the skull base because of the bone destruction. And treatment could be this primary treatment, the supplementation with the calcium supplements, or the ones that break down the calcium and take the hypercalcemia that occurs in the blood. It is due to the bone resorption, so the bones lack the calcium, while the blood you've got more than enough of the calcium. So it means it does not give you the idea. Increased calcium in the blood, it doesn't necessarily mean that but the bones are rich with the calcium. So you should do the densitometry. This is the instrumental, how to say, the defines the bone density, the densitometry, and the calcium concentration in the bones, and defines the risk of the fractures in the different bones. It could be defined in the radial, ulnar, femoral, or the other bones as well. Okay. So, and secondary hyperthyroidism, which is not due to the parathyroid gland tumors or the defect or something caused with the parathyroid glands, but secondary due to renal failure, due to prolonged dialysis, washout of the calcium, and so forth. So the patient is hypocalcemic and has hyperphosphatemia. Anemia means in the blood we've got a lot of phosphate, but we have decreased the calcium. Then hypercalcemia was the feature of the primary hyperparathyroidism, and in case of secondary, we've got vice versa. Okay, and there was a case of the secondary parathyroidism, and usually the diagnosis is defined with the anamnesis. So you just ask questions, and when you know the history of the patient. So this patient, for example, was on a long-term dialysis due to her kidney failure. So the diagnosis and your clinical medical mind just drive you to the right direction to the diagnosis of the secondary parathyroidism. Okay, that was the intraoral radiography done, and this was the differential diagnosis between cherubism, between fibrous dysplasia, Paget's disease, and osteopetrosis, and all four of them we have discussed in the previous lecture. So we talked about paraneoplastic syndrome, which is the hypercalcemia of malignancy, which is the sign and the symptom of the neoplasm somewhere else during multiple myeloma, for example, during some tumors, hypercalcemia. One of the signs of the one of the paraneoplastic syndrome is hypercalcemia. Okay, it does not necessarily have to be linked with thyroid dysfunction or renal dysfunction or dialysis, but could be because of the cancer somewhere. So it's just paraneoplastic syndrome that indicates the existence of the neoplasia in the body, which is not identified yet, but will show up later, just after the syndrome is detected. Okay, differential diagnosis and treatment, and the cherubism, because or cherubism, yeah, they pronounce it in both ways. And yes, this is the autosomal dominant genetic defect, which is expressed in both homozygotes and heterozygotes as well. So it's just enough to have to be the carrier of the one affected allele to inherit the cherubism, and males are slightly more affected than the females, so male predominance here. And yeah, it usually does not cross the bony suture. It doesn't occur in any other bones than the jaws, and usually the mandible is affected jaw, and this is the case. Here is the city of the case, and it's really you cannot mix it with the other um, reasons of the mm, bone change because of the specific facial features this patient's own, and they're usually very apparent in the children because it's childhood disease that progresses, and usually it's de degrade or resolves in teens. If it does not, only then it needs a surgical interference. Just in this case, this patient in his teens that undergone the total resection of the mandible that I think was not necessary and traumatic and beneficial, but then he undergone the transplantation, let's say implantation of the plastic surgery. This is implantation of the artificial jaw. And the other case, which definitely necessitated the surgery, because this is 9-year-old, this is a 17-year-old, so it just progresses on the both of the sides, while it was just on a single side, just progress and it doesn't resolve by years. And this was resected the mandible bony
Sorry,
structure.
doctor, only with surgery, not by orthodontics?
Yes, yes, orthodontics do that.
No, the slide 22. We can make orthodontics for face correction.
I mean, you mean implantation? Implantations
No,
do.
no, slide 22, doctor.
Slide
Yes,
22.
this one. We can make like face correction with the orthodontic doctor.
I think yes, because this pathology is purely orthodontic. But implantation, if it's required, then plastic surgeons are involved.
More
But
better than surgery.
yes, the maxillofacial surgeons perform the surgeries without any restriction. It is involved in the residency program of the maxillofacial surgeons.
Yes.
Mhm. But the plastic surgeries are usually attending the surgery if there any implantation is required, and even neurosurgeons can attend because the facial nerve and trigeminal nerve fibers are here, and in order to preserve those nerves, maybe the surgeons would need them a
Yes.
consultation of that. Okay, because it looks like when you first look, it's but it's quite complicated because their area is a very sensitive area,
Mhm.
rich with the fibers, the blood vessels, and one wrong move, if you damage the nerve fiber, facial nerve, for example, you leave this part of the face paralyzed. The mimic muscles will just simply be paralyzed. So very dangerous and very accurate work is
Yes, it's
required.
very dangerous surgery.
Yes.
So,
And the phrase syndrome could be the result also if we not careful with the parasympathetic fibers of the
yes,
nerve
yes, yes.
tissues. Yes. And this was poster picture. Very good outcome. And by the way, this is the Stearns and your book out of your book. Okay. So segmental maxillar dysplasia, and then this is the example of that, the pre-op and post-op pictures of the maxillary dysplasia, segmental one. Segmental osseous dysplasia, this is the 10 years difference between these pictures on the one side, and now you see the symmetrical jaws. And this focal cement osseous dysplasia, as you can see here, this is the local bony formation. So like osteoma formation, but it's called cement osseous dysplasia because it's it has well marked margins and it does not go further than the so it's localized. That's why it's called focal cemento osseous dysplasia. After resection, you see the content is the bones fragment, and the fibrous dysplasia, which is I think most horrific case here presented
Oh my God.
ever. Yes,
It's
with
real
the
case?
yes, it's a giant mess, fibrous mess with fibrous connective tissue that deform. This is the face of the girl,
How
and
she
this is
live?
what?
How she live without oxygen, without food, without anything?
So yes,
Without faith. She live without
with
faith.
the she probably was fed with gastrostoma, so the tube
Yeah.
inside her stomach, and I think the nostrils are totally occupied here, and your mouth is impossible to. But I don't know. The breathing should be difficulty because I don't see any tracheostoma, and this is the intraoperative picture. So all these connective tissues with the osseous parts,
Yeah.
and this is the post-op picture.
Doctor,
Finally,
I have a small question.
yes, please.
The fibrous dysplasia start small and develop by time.
Yeah. Yeah.
Time this girl, she didn't see his face.
Yes. I don't know why do people do that,
Why?
but because their wrong beliefs or because of the fears. But I think nothing is more fearful than this. Yeah, when the
Yes,
look in the
it
mirror.
needs too much time, like 1 year, 2 year to
Yes, yes,
like
it's
that.
not happening within
It's
the
not
days.
very
It happens within the years to grow this type of math. Yes, I don't know why they don't come to the doctor because of the fear. Maybe the economical or social issues,
economical, yeah.
and yeah. Yeah, who knows? But the some of the fibrous dysplasia grows not that fast, but some of the tumors, some of the tumors, they really grow really fast. For example, I will try to find one of the pictures that happened during the mens. 1 month, it doubled in size, so it was like the hugest tumor we have ever resected. I think I don't have it right now, but I will try to find it. Um, I will take a break and find it, okay? And I will show you the
Oh,
huge tumor that it grew twice as the size that it was in 1 month, okay? So just I will take 10 minutes and be back to you, okay?
okay.
I finally found it. Okay, so this hi back. I'm back.
Hi.
Welcome back. Okay, it was 2 years ago. It was 2018. Like the woman, 50 something, came to us from the village far from Tbilisi, and she had a tumor of the size of the apple on the back, near the vertebral. It was not quite our call. It was like near the scapula, so like an apple. So we wrote all the papers, medical forms, and sent her away. And she said that I will come back after the holidays, like it was winter holidays or something like this. I will come back after holidays in 1 month. She said that, and we just with calm heart we sent her away. And because it was nothing like the mortal one, it was just a tumor size of the apple on the back of her, under the skin. It was palpable, and on the scapula. Okay, so it was nothing like it could kill in a month, right? And we just let her, and she came back after 1 month, and remember the size of the apple, and now the size the tumor had. Okay, so this is the tumor of her. Oh, it's not like this. Can you see it?
Yes, it's too large.
Yes, yes.
Like
Apple,
apple.
yes, apple turned into the watermelon, I think. And this is the intrasurgical after the resection. This is the
Oh.
mass we resected. Yes, this is the mass we resected within the scapula itself, because and this is
How
the
much time
part of
like this surgery take?
it. It weighted like 5 kilograms. We waited,
Oh,
and surgery went for 3 hours. This is the mess, the whole mess. Yes, this is the side view of the yeah, and this is another thing, and this is
security.
happy me. This is happy me on the surgery.
Yes.
Yeah, I was like, yeah, cool. Like
Can
they
I
can you?
ask
Yeah.
what caused? Do you know what like possibly caused it to grow so fast within a
This
month?
is sarcoma. This sarcoma is very malignant tumor, and it grows
Fast.
very fast. Yes, there was
Yes.
sarcoma. Yeah, sarcomas go very fast, so you cannot recognize them with just one glance. We thought it was the benign tumor. It's not our fault. The patient has to choose whether to perform the surgery or not, because it was not an emergency surgery. And she chose to not to perform it at the time she visited us first, and waited for months to grow like the huge.
It
But
needs
fortunately, we were able to resect it totally, and 2 years passed it, and she's still alive. Nothing. Yeah. No,
it,
so 2 years, it's good for sarcoma.
it need chemotherapy or not after
I think yes. I think she did local radiotherapy, not the
radiotherapy.
chemotherapy, but radio, yes, elimination. And I have also one good case to show you. I have dozens of them. Like my phone is like a horror movie. Yeah. So this is the 5 years old child with the hydrocephalus. Yes. You
Hydrocephalus.
see?
Yes.
Yes. And the size of the skull, it's showing 80 here. So 80 centimeters was the circumference of the 5 year old child's head. And like it was half of the body size. And
Yes.
we did what we did it. We printed his skull, like 3D printed.
3D printer. Yes.
Yes, with the 3D printer, we printed his skull. Like this was with the 3D printer. This was the we printed it, and then we cut it. Like we wanted to reduce the circumference by 20 centimeters. Like we cut it like this. This is my hand. This is now cut already, because this is the sagittal sinus. We cannot actually touch it, because the patient will bleed out and will die on the table. So we left this part, but to diminish the size by twice and circumference. So we cut the 3D printer, That's my chief, and that's me, my hands, and then reconstructed back with the same scalp. So, like my seeing, we reconstructed with piece by piece, like half by half, and we performed the surgery. So I will actually, this is how we did it. So this is the other half, which is now, which was like this, and we did like this. So you see, the difference was 20 centimeters, like this. This is the final shape. So this is the final shape now, and I will show you. This is the final. Now I will show you them post and
The
intro.
surgery. I want to see the surgery.
Yes, and this is the after the surgery. You remember this one? This is the
Yeah.
pre-surgery, and this is the intrasurgical. We already this is the brain, and now we have reduced the half of the hemisphere. You see, this is the brain dura mater, and this is the post-surgery.
Yes.
Yes, you see the reduced part. So it was reduced by 20 centimeters. It was one of the first cases. One case was done in the, it was 13-hour surgery. It was February 14 of 2018, 2 years ago, actually. You see here how the half of the skull is reduced, half of still is
Yes.
have to be reduced. So yeah, we piece like puzzle. We build up the new skull for
Yes.
this baby. Yes, like puzzle. And this is the final look, like, yeah, very good outcome. And the patient had no has no neurologic deficits after this. We did VP shunt, of course, because the half of the mess was with the
The
CSF.
scan.
So we did shunt as well. And this is one of a kind of surgery. No one has done something like this. Just one case there was in
In Georgia.
yes, it was performed by Americans in, I think, in Brazil. In India also was one case, but unfortunately the kid died. But our kid survived, and it was, I think, but there is when we are looking for answers and in the internet, when we connected with our foreign colleagues, no one had the experience of performing such a surgery, and if anyone had it, they all had a little outcome, and everyone warned that don't do it, don't do it, like the don't do it. And we thought so much about it, but we couldn't do more harm than all of what already was done. The patient could move his arms and legs, but was
Yes.
paralyzed because he couldn't move his hand because the head was mess of the whole body, and he was like lying, and skin lesions were because of constantly lying position, and the parents could not take care of after him because simply could not lift the baby's head without yeah, and you could feel the fluid while touching it. So we had no choice. We did it, and yeah, it was all around the media, and that case got us famous. And my chief is now really one of the best in the Tbilisi, and because of this case, everyone knows him. And yes, the baby leaves, and his neurologic symptoms improve. He is playing, he's sitting, he cannot walk because he already was 5 years old. We did it, and
Can walk
but
or
he can sit. He cannot walk, unfortunately, but he can sit and just playing and speaking. He is speaking as well.
he do
He learned
physiotherapy?
new words. What?
He do physiotherapy for
Yes,
walk.
physiotherapy they perform, but the kid is from a poor family. They cannot afford that much. The parents have five other kids, and they left in the orphanage this baby before the surgery. That's how we found him. The orphanage connected us, and that we went to see him lying there, and we heard the words of coming. He was calling like his name, and we couldn't believe that this kind of pathology was able to speak, because it's incomprehensible. How was he able to do the things he could do? Because the speech is almost unbelievable in this kind of pathology. Speech was preserved, And after the surgery, the parents took back the kid from the orphanage. So that was a
Yes.
good thing also.
Yeah. We can
Okay.
attend like this surgery, attempt to watch it or not.
Uh, yeah, I can send you. I have shared it on the Facebook. The whole interview with a 3D guy
No, if I
with
want to attend some surgery, I
Oh,
can.
you want to observe? Yeah, of course you can, but unfortunately we are under strict quarantine, and all the planned surgeries now are canceled till the March 2021. Just the emergency surgeries, which we cannot plan, which can happen at any time of the day and the night. So I cannot really tell you when we have surgeries because it's
Yes, it's
yeah, it's emergency surgery. Who
emergency
knows
one.
when? So, but after the match, I hope that we will be able to join,
I
to
like to
meet each
join
other.
surgeries.
What?
I like to join surgeries from.
Oh, and that's nice of you because I have taken some of my students to the OR. They took pictures, and they really like the surgeries. Brain surgeries are very, very, as I would say,
Yes,
influentive and very visually effective
yes.
to see.
First surgery I
Yes,
was attending
yes, my
was
Facebook. You, of course, you can. Uh, uh, that's how I am. This is my Facebook. You can find me like this. You can. Yeah, I'm friends with
without a
Hussein.
profile
Yeah,
picture.
yeah, yeah. I only have medical ones. I never add anything. Just
Yes,
the pictures that my friends share with me. Yeah, they shared the scoliosis yesterday, which I've shown you yesterday. Before
you
that.
have medical one.
I don't have my own pictures
Yes.
that the ones that my friends share with me because I'm not so active. I'm just
No, not
using.
on your Facebook. Medical page you have.
Yes, my clinics, Hudu Shaori clinic. You can check it out. Hudu Shaori as well. And the Gegia is my chief, so you can also check his page. Not Gegia, but or Mhm. Yeah. Thank you. So let's just quickly finish up our PPT then, and I will let you free because I have a lecture after this 4 hours. So this was the outcome, and we talked about Paget's disease. Yeah, I give you the case, so I'm not gonna repeat this one. We talked about osteopetrosis and yes, of the maxilla and mandible, which also involve the C-spine, cervical spine here. And I think I haven't talked about this one, so I will open up. So it's called BIONJ or BIONJ. It's a biphosphonate induced osteonecrosis of the jaws specifically, because it does not involve other bony parts of the body, but just jaws uniquely. So the world's first description, it's very, very new disease. It was done in the 2002, and after this first case, there after in the next 10 years, over 111 publications to textbooks of 15,000 cases were reported in the literature. But the first case was reported in 2002. Okay, like 18 years ago, quite a few. It's like 21st century disease, but it doesn't mean that it didn't exist before, just like it was reported to the medical stuff at this point. So the cause of biphosphonate induced osteonecrosis of the jaws or beyond is the, I think this is my KLR, so I will yes, I will confirm. It's a toxic effect of the nitrogen containing biphosphonates of the normal osteoclast and its precursor cells and the bone marrows. And specifically, bisphosphonates inhibit the enzymes farnesyl synthase, which is the part of the mevalonic branch of the pathway common to all the cells. And this is how the near nuclear loss is looking in the osteonecrosis, the breaking down, simply breaking down of the bones due to the biphosphonate induced mechanism, and how it is induced usually by the medicine that contains the biphosphonates. Okay, and the oral biont is the mostly result from the alendronate, that is Fosamax or Merck, or the pyrisidronate, or the others that contain in their structure biphosphonate, and they induce usually the oral bionge, or the also we have a case of the intravenous bionge, which is less common. Oral one is the most common. Okay, all three of these drugs are used to prevent or treat osteoporosis, so they supply their supplements for the osteoporosis. It's the poor bones, for the poor bones that occur after the fifth decade of the life, and most commonly in the postmenopause women, females. But these drugs itself that are supposed to treat osteoporosis, they cause the osteonecrosis of the jaws. Okay, oral biopsy is seen less frequently than the intravenous and is less extensive and less severe form. It's responsive to the discontinuation of the biphosphonate, so it's called the drug holiday. So when you just stop this, cease the medication, the progression of the disease also stops, and a minor debridement surgery during a drug holiday is what makes the outcome favorable. So this is the biphosphonate induced osteonecrosis in the posterior mandible. You see the bones are destructing here. And this is the biphosphonate induced osteonecrosis in the maxilla. Yeah, bones are destructing. And this is on the hard palate. You see this maxillary torus is osteonecrosis, or you see actually under the mucus, you see the destructive bone. And this is the osteonecrosis of the posterior lingual cortex of the mandible, an array of the high occlusal load. Yeah. And why only the jaws? Why jaws? Because the disease process always begins with the alveolar bone exposure. However, unique trochanteric fractures, it means under the trochanter and the neck of the femur, sometimes also are I would say reported as a case, have been caused by the long-term use of the 6 years or longer use of the Foramax, representing either the brittleness induced by the biphosphonate or the actual bone necrosis. Could be both of the reasons. The predilection for the jaws is due to the fact that the alveolar bone of the jaws remodels at the rate of 10 times faster than that of the long bones because of the occlusion and the denture wearing, and therefore much more dependent on the osteoclast-mediated bone remodeling, and that's why they are affected in the first line. Okay. So differential diagnosis is usually evident by the patient's history, clinical observations, or exposed bone, or the certain radiographic clues. So if you know the history and the patient is on the treatment for osteoporosis, we can suggest the diagnosis, or if we see the picture or jaws only included, and other entities that can cause exposed bone, such as osteopetrosis, which we know, osteoradicular necrosis, or mucormycosis, florid cementosis dysplasia, and rarely a suppurative osteomyelitis. Those should be ruled out of the differential diagnosis by using the history collection, by anamnesis, by using radiographs, knowledge of the disease mechanism, and so on and so forth. So this is the stage one beyond by the virtue of the one quadrant of the exposed bone. You see, this is the first stage, just first one. And this is the stage two. You see exposed bone within the, not just this part, but this so deep. So exposure is very deep, and this called stage two. And this is the stage three when you see the fractures or pathologic fracture due to the bone fragility. And this is also stage three with the secondary infection and the cutaneous fistula in the cancer patient who received the somata for the osteopetrosis. Okay. And that picture I think you have shown you. This is also your skin is underlying skin is necrotic under the necrotic over the necrotic bone is showing the necrotic bone. So this is the skin defect because of the infection and fistulas. And after the surgery, so this is exposed bone osteo necrosis caused by bisphosphonate. Mm, and this is the jaw bone, fractured bone of mandible that was resected, and this plate was inserted instead of the extracted bone, and then skin flap was added to cover up the skin defect. Okay, this is pre-surgical view, and this is after the surgery. Okay, and here we have also sequestrum removed from the straightforward deafness procedure after the 6-month drug holiday. So 6 months drug free and then removal of the petrosis part. And this is the healed bone area. And after the holidays, it is possible to insert the prosthesis, and you see the skin. Tooth dentures could be possibly inserted after the drug holiday. Okay, and this is the exposed necrotic bone in the edentulous mandible caused by 10 years of the Foramax use. You see stage 3, and this is the planned resection and the incision designed for the stage 3 oral beyond. So resection of the mandible was necessary with the condyles here within the condyle. So this is the exposed mandible prior to resection, how it looks like destroyed and fractured. And this is rigid titanium reconstruction plate. Um, it's still not resected, but it's just placed, and the form is shaped prior to the intact mandible prior to the resection. Then the resection is performed. You see during the emergence of the healthy bone spaces. Uh, then the replacement of the rigid titanium plate in the same location as the prior resection will maintain the correct condylar position and the occlusion. Okay. Mhm. And this is the outcome. The patient is resolved beyond with the facial form and the jaw function maintained by the rigid titanium plate. Okay, it's not symmetrical, but better than it was. Definitely necros free. Okay. And you also at the end of the chapter, you're gonna meet the other systemic disease like anemia's effect in the bone. For example, this is the example of the beta thalassemia, severe maxillary expansion due to marrow hyperplasia in a 17-year-old with the beta thalassemia. Thalassemia is the hemoglobin is made of the alpha globin and the beta globin chains. And when we have something wrong with the beta globin chains, we've got beta thalassemia. It means they are less than the alpha, and they just precipitate and cause the hemolysis and anemias. And this disease can cause secondarily can affect the bones, like the sickle cell anemia also can affect the bones. And the rest you're gonna read in the chapter. Okay, do I agree with using your brain? Okay. Thank you very much
Okay,
for
thank
your
you.
time, for your attendance, for your attention. And congratulations again with the midterm too. And the next week's gonna be the final lectures of this semester. I hope I'm gonna meet you in the next semester as well, maybe with the pharmacology or with the other subjects that you have to pass.
I was finished the pharmacology.
Oh, you passed, right?
Yeah,
Yeah, you were with me. Yes, 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 I remember. And Philip also was,
and
yes.
fundamental too.
Oh, yeah. Okay, thank you very much. I wish you a best weekend and a good week ahead of you. And Merry Christmas and Happy New
Merry
Year is
Christmas
coming
for
forward. Yes, yes. Thank
have
you. Thank you very
bye
much. Bye bye. See you on
bye.
Tuesday. Bye.
Bye.